Hello and welcome to this webinar about retinal imaging. Today we will talk about new capabilities for examining the retina at the cellular and microvascular scale. Indeed, we are introducing new features in our RTX-1 AO camera, and these features expand its use into novel exploration of retinal structure and function, and other features also streamline the imaging procedures for adaptive optics in clinical studies. Today's guests are longtime users of the RTX-1 device, and they are also the first users who have tried these new features. And today they very kindly agreed to share their experience and vision with you. So now I will let Nicolas introduce our guests.
Hello, everyone. Today we are welcoming three wonderful guests who are experts in three different disciplines. Michel Paques is a professor of ophthalmology at the 15 National Eye Hospital in Paris. He's a leading expert in the field of adaptive optics retinal imaging, a technology that he has developed and applied to a wide range of diseases. Carolina de Ciuceis is an associate professor of internal medicine at the University of Brescia in Italy, and she has made extensive use of AO imaging in her research, with the goal of improving the prediction and the monitoring of cardiovascular risk. And Danilo Andrade de Jesus is assistant professor at the Erasmus Medical Center in the Netherlands and principal investigator of a joint project with the Rotterdam Eye Hospital. He specializes in image processing and artificial intelligence applied to ophthalmology, including the development of AO biomarkers for inherited retinal diseases. So as you can see, there is a great diversity of expertise on this panel. And now let's start the discussion.
Thank you, Nicolas, for introducing our guests. So we open the content of today's event with the first topic, which is about RPE imaging. So on the RTX-1 device, we have added this TFI module. So you see it's an additional module in front of the camera. This module adds a new illumination mode, which is called transscleral. It sends the light that illuminates the retina through the sclera in an oblique way. And this enables to reveal the RPE layer, which is under the photoreceptor layer. So here in this example, this is a healthy retina. We see the image of photoreceptors that is obtained with the light through the pupil. And we see another image which is acquired simultaneously and which uses the transscleral illumination. It shows, as you see, a different pattern. So here it looks like a honeycomb pattern. It is actually what is consistent with RPE cells. And this is it illustrates the new capabilities that this module adds to the RTX-1. So now I want to ask Michel at 15, what is your interest in this type of imaging?
Yeah, so as you said, we've been using the TFI system for quite a while now, and it's very interesting to see RPE cells, but maybe even more interesting, well, at least in my clinical practice, it's because it's a very good way of detecting migration of pigment. And since we do an intensive amount of work now on age-related macular degeneration, it appears that the TFI image can detect pigment dispersion at a higher resolution, even that with the RTX-1, which is already highly performing. Here you have on the left the RTX-1, the montage of RTX-1 images in the macula of a patient with atrophic AMD. And I highlighted some zones in which you detect some presence of pigment, but with the TFI image on the right, you have even a much crispier view of these pigmentation. And you detect pigmentation here, for instance, which we don't really see it here. And this is true also for this pigment spot here and here. And so we're having a better view of the spectrum of hyperpigmentation. Another interesting feature as well is that we detect much better the drusens. Here we have a case with the RTX-1, although we know that using some protocols of acquisition with what we call gaze-dependent imaging, we can detect the better some small drusens. The RTX1 was quite limited for large drusens, and the TFI shows very nicely of this example the collection of drusen of different size to the macula of this case of early AMD. So you see the image is better for AMD not only because we better see pigment dispersion but also drusens.
And Michel, so how can this new imaging possibility, why it is interesting for you, and can it improve the prognosis in AMD?
So, so what we're interested in our group with AMD is the dynamics of progression. How does feature change, and can we detect activity of the disease? And I'll show you an illustration that detecting pigment dynamically, that meaning doing several examinations over time, may detect with high sensitivity the activity and probably the inflammatory component of the disease. Here is an animation. This area seen with the RTX1, which is somewhere here close to the fovea. You see the atrophy is here, the RP is here, and this is the RTX1 image. And the TFI image, already, as I mentioned, we have a better viewing of the pigment migration with TFI. And here is the animation of the same case. I think it's over several months. And you can see the remodeling of the pigment dispersion, so showing that they're not just passive deposits, but they're probably integrated in a cell. If something moves, it's highly likely that it's because it's within a cell. So this reflects somehow cell metabolism. It may be an interesting parameter to understand the course of the disease and its activity.
Thank you, Michel, for sharing with us the interest of this new imaging of the RP layer, and not only the RP cells, also the alterations. Now I would like to move to another topic, which is about microvascular imaging. So indeed, the RTX1 doesn't only enable to image the cells in the outer retina, it also enable imaging the vessels with a very high level of detail. As you can see here on this image, we can distinguish on RTX1 images the lumen of the vessel and the thickness of the walls for retinal arteries, which is an important capability, which is not possible with other imaging systems. So I want to ask Carolina this time. So Carolina, you are a cardiologist. Why have you adopted high-resolution retinal imaging in your research? Why is imaging the retina useful for the research in cardiology?
Thank you, Marine, for the questions. And hypertension and other cardiovascular diseases are associated to macrovascular alteration. However, to investigate the macrovascular district is not an easy task. For several years, the best indicator of macrovascular remodeling has been considered the immediate lumen ratio of subcutaneous small resistance arteries, which represents the earlier form of target organ damage in hypertension, but it requires a local invasive procedure for the isolation of the vessels. The microvascular retinal network is probably the only macrovascular bed that may be directly visualized, as it shares anatomical and physiological features with the same vessel in other organs like heart and brain, and therefore it may be considered a window to the heart or to the brain. However, for several decades, the available techniques for the assessment of retinal microcirculation and traditional fundoscopy failed to accurately detect the early microvascular structural changes in hypertension. Among the different non-invasive approaches proposed in the last year for the evaluation of retinal microvascular vessels, and adaptive optics may provide a very accurate estimation of false lumen ratio, which is closely related to the immediate lumen ratio of subcutaneous small resistance arteries. And the retinal arterial wall-to-lumen ratio is related also to blood pressure and other markers of hypertension-mediated organ damage. And most importantly, it has been recommended from the last European hypertension guideline as a promising indicator of clearly microvascular retinal remodeling in the evaluation of hypertension-mediated organ damage.
Thank you. It is very interesting to know that it is now cited in a guideline. How or more have you established with your studies some prognostic value of the AO imaging in relation with cardiovascular events? And maybe there is some slide you want to share.
Yes, we previously demonstrated that an increase of median-lumen ratio of subcutaneous smaller distance arteries evaluated by the macrobiography and basic technique predicts the development of cardiovascular events. And therefore, we aim to investigate whether the retinal arterial wall-to-lumen ratio evaluated with adaptive optics may have similar prognostic significance. For this purpose, we re-evaluated almost 250 patients previously submitted to adaptive optics after a follow-up time of 4 years and a half in order to assess the occurrence of cardiovascular, non-cardiovascular events. We observed that the wall-to-lumen ratio of retinal arterial were higher in patients with event compared to patients without event. And more interestingly, by looking at the Kaplan-Meier survival curves, we observed that the patient with a wall-to-lumen ratio of retinal arterial above the median value of the wall-to-lumen ratio of the population have a higher incidence of total events and compared to patients with a lower wall-to-lumen ratio of retinal arterial. And similar results were confirmed after a restricted analysis only to the cardio and cerebrovascular events. And this suggests that the wall-to-lumen ratio of retinal arterioles obtained by adaptive optics may provide a reliable and invasive approach for the stratification of cardiovascular risk and for hypertension treatment decision.
These are really important results that you are sharing with us today. To go further in the investigation of retinal vessels, we have added one new feature related with the assessment of vessels in the RTX1. So this is flicker stimulation. So why have we added the flicker stimulation? It's because there was growing need for functional assessments, and we had requests for this kind of stimulation in the RTX1 in order to assess what is called neurovascular coupling at the level of precision that is enabled by adaptive optics. So neurovascular coupling is a change of retinal vessel caliber, as you can see in this animation, that is caused by the response of flickering light, which stimulates the neuron. So this is why we have added this stimulation. So the RTX1 can now deliver flicker to the eye that is being imaged, and the capture of the AO image is automatically triggered at the end of the stimulation. And then it's possible to measure the size of lumen or wall-to-lumen ratio between images without stimulation or with stimulation. At Karlsruhe Hospital, in a preliminary project, some first results have showed that flicker-induced response could be measured with micrometric precision with the RTX1. So, Carolina, you have started also experimentation with the flicker feature in RTX1 at your center in Italy. What do you expect from this assessment of neurovascular response for your field?
Our interest in the assessment of neurovascular response is related to the possibility to investigate the microvascular functions with trigger light-induced dilation. After repeated stimulation of filtering light, both the arterial and the venous dilate according to the principle, as we said before, of neurovascular coupling. But the molecular mechanism behind the neurovascular coupling are quite complex and involve both direct vasodilator release from active neurons, as well as interaction among cells such as neuron, astrocyte, and blood vessels. In this context, the release of nitric oxide, which we know that is a marker of endothelial function, seems to play a crucial role, and it further exerts its action by modulating the glial regulation of vasomotor tone. Despite of neurovascular coupling doesn't have to be considered as synonymous of endothelial function. However, in the absence of a local eye disease or systemic neurological disease, which may be associated to a dysfunction of neurons or glial cells, trigger light-induced dilation could provide some hints regarding the function of the vascular endothelium. And accordingly, trigger light-induced dilatation has been observed to be blunted and impaired in patients with untreated hypertension or other cardiovascular risk factors such as dyslipidemia, or in patients with diabetes mellitus. And interestingly, it has also shown that flicker light has a predictive value in terms of mortality in patients with cardiovascular disease or with chronic kidney disease.
So this is a very interesting perspectives that you are explaining to us today about what RTX1 adaptive optics imaging and this new possibility to stimulate the eye before acquisition might enable in the future in your research. So thank you very much for sharing that with us today. As you saw, we have added more functionalities and imaging modalities with this TFI illumination we presented at the beginning to the RTX1 device. What we have also improved recently is related with usability. Indeed, we have answered the needs for more systematic procedures for AO examinations, as well as simplified procedure for follow-up examinations. So in the RTX1 now, there is a number of standard protocols that are suggested in the interface. 3 are represented here as an example, but we have added more that were inspired by studies that have been published. In the device, the capture of the multiple AO images of a protocol is guided by the user interface. So parameters such as gaze position, the modality to be used, and other parameters, they don't need to be set by hand for each acquisition. When you have chosen a protocol, they are all preset, like as a list of pictures to be taken. So you just capture an image, and then you move on to the next item of the procedure, and you can capture the next image, and so on. And when you are done, all the images that you have captured can be easily assembled as well in one click in a montage to obtain a larger AO image of the retina with high details. With this protocol feature, we have also made the follow-up exams easier because there is a follow-up protocol which replicates, so you have seen here in the animation, it replicates the previous sequence of images that have been captured on a given patient, and it guides you for taking again the same images, and this enables to accelerate the workflow. Images will also be automatically registered to the baseline pictures automatically after the acquisition. So the aim of adding these fast protocol workflows and the follow-up workflow in the RTX1 was to make it easier and faster to execute the standardized AO imaging procedures with multiple acquisition. Erasmus Medical Center in Rotterdam is one of the first centers who have tried this new feature in the context of the AO Vision project. And we are really eager to hear their feedback. But first, Danilo, maybe can you introduce the AO Vision project for the audience?
Sure thing. Hi, Marine, Nicholas, Michel, Carolina. Thank you for the kind introduction and to the invitation to this webinar. It's a pleasure to be on this panel together with Michel and Carolina and to have the opportunity to share the work that we are currently doing at Erasmus MC and Rotterdam Eye Hospital. All right, so the AO Vision project is a project funded by the Health Holland with the support of Imaging Eyes. So it's a project that we started more or less 2 years ago with the goal of developing new methods and biomarkers using adaptive optics imaging for the diagnosis and follow-up of inherited retinal diseases, so IRDs. So as you know, IRDs are largely incurable, but the treatment landscape is rapidly evolving. So this means that different options are at the moment under investigation in order to develop therapies that could either slow, stop, or even reverse sight loss. So this includes, for instance, gene therapy. But to evaluate the efficiency of these new therapies, quantitative and objective methods are needed. So that said, and given that the primary cell types affected in IRD patients are photoreceptors, the RTX1 adaptive optics retinal camera offers an excellent opportunity to image these photoreceptors and consequently understand the pathogenesis and progression of IRDs in a microcellular scale. Therefore, in our project, in the AO Vision project, we hypothesized that applying artificial intelligence techniques to high-resolution retinal images from AO technology will enable earlier and more accurate detection and progression assessment than the current conventional methods. And for that, so the AO Vision team has worked on several things, including the standardization of retinal image acquisition. And we are at the moment building a large and structured database of AO images and annotations, which already includes more than 200 subjects. So this has allowed us to develop a method for the automated detection of the photoreceptors, which you already can see here some results, which we will continue improving during the course of the project, as well as to continue developing new ways of quantification certification of IRDs.
So Danilo, you have mentioned the importance of standardizing AO imaging methods in this project. So can you tell us a bit more about what you have undertaken in the AO Vision project?
Yeah, that's a good question. Thank you for that, Marine. When we talk about standardization, we can talk about, for instance, standardization in terms of image acquisition, or we can even talk about standardization in terms of image annotation, or even in terms of image interpretation. So all of these are needed and important in AO imaging. So we can not only maximize the information we want to retrieve from these images, but also assure the reproducibility of our results. That said, the design of the image acquisition protocol was something we paid special attention at the early stage of the project. So imaging of IRDs with adaptive optics holds a great potential for research and clinical practice. But as we know, it's still in its early stage. So this means that when we started the project, more or less 2 years ago, and to the best of our knowledge, there were no standard image acquisition protocols for IRDs published in literature. And although that there have been some interesting works published in this field, studies have always been adapted to their own needs and resource settings. So this raises the question on which protocol shall we use and why? And therefore, when we started the project, what we did was also to try to reach other scientific researchers with a vast experience in AO imaging, namely Dr. Kyoko Gocho from the Kansas Hospital and Dr. Daniel Rochendale from the Lions Eye Institute in Australia, which I would like to thank for their contribution in this project as well. And after several interactions, so together we came out with what we think that is a suitable protocol for imaging IRDs. In this specific case, retinitis pigmentosa. So here you see pretty much a summary of what is our protocol. And let me just quickly explain and guide you towards the protocol. So we start with a fixation centered image at 0 degrees to check the patient's preferred locus of fixation. Then we have like a band pattern from the macula to 10 degrees temporal for imaging any changes that may occur from the mid-periphery to the macula. And this is very important, mainly in retinitis pigmentosa, because we know that it starts from the periphery to the center. And then in addition to that, so we have two additional rows on the superior and the inferior perifoveal region. So this is very important in advanced stages in order to see the atrophic ring, as you can see here in this image. And so then we can also do the follow-up of this atrophic ring. So this pretty much in a nutshell summarizes what we did in terms of standardization of the image acquisition.
So we can see from the montage that you are showing right now that this protocol of acquisition that you have developed seems really to enable to pick up yes, interesting features from the RP in RP patients' retina. So how does the new fast protocol workflow, how as we call it, that I introduced earlier, how does it help you in the project?
Thanks for the question, Marine. So yeah, as we could see previously, so our image acquisition protocol requires acquisition of 21 images, and we can also see it here. So this requires some special attention by the colleagues that are acquiring the images, so that all images are acquired at the right location. So at Erasmus MC, we started by training 2 of our colleagues who have mastered the image acquisition over time. However, as you can imagine, it's not possible to have always the same people acquiring the images. And AO being like a relatively new imaging technology, it has a slower learning curve when compared, for instance, with optical coherence tomography or color fundus imaging, which are imaging modalities that the colleagues in the clinic are very comfortable with. That said, this new protocol has brought several advantages to the use of AO in clinical practice. So among those, and from the experience we had over the last weeks, I would like to highlight 3. So one of them is speed. So there is a significant improvement in terms of speed in such a protocol like ours, where more images are needed. So this means that less acquisition time will be needed for the acquiring all of these images, which is preferable for the patient and also for the clinical workflow. Another aspect to highlight is the education and training. So the learning curve now is much faster. So it's much easier now for a new colleague just to follow an existing protocol than just to put all the coordinates for an extensive protocol like ours. And finally, so the last but not least is the robustness and quality. So with this new functionality that RTX has now, there is much less room for mistakes. And this means that like the people that are operating the machine can focus more on the quality of the image.
Thank you for highlighting these 3 positive outcomes from this feature, this new feature that you have seen after trying it for a little while. So I will let Nicolas take the lead now for the rest of the discussion.
Okay, thank you all for explaining the reasons why you have encouraged our company to include these new features in the product, and it was very rewarding for me to see the great results that you showed quickly today. Now I'd like to ask each of you how you are going to implement these features practically in your work. So maybe Danilo, how about the protocol workflows that you've been trying for a few weeks? How do you see their use at your facility?
I'm glad that you asked that, Nicholas, because it links to the first question regarding the importance of the standardization in AO imaging. So one of the problems that we faced so far in AO vision was the comparison of our results to those reported in other studies, not only in terms of self-counting, but also the patterns that we observe in these images. And this is mostly due to the lack of standard protocols in the field. So I think the deployment of this new protocol functionality will certainly boost the standardization and standardization of acquisition protocols, and in this way improve the comparison of results across like studies or medical centers. In addition to that, I think that it will also contribute to the development of normative databases, which is something we have also started working at the moment. And I would like to take this opportunity to mention that that we will start acquiring like images to set like a kind of normative database with the protocol that I just showed before. And I would like to extend an invitation to any center that is using the RTX1 camera as well, just to join us in setting up this normative database. So this will mean to acquire images and collect like some clinical parameters in a number of healthy controls with the current protocol. But returning back to your question and in line with what I just mentioned before, I think in terms of like speed, training, and robustness, I think this new protocol functionality will facilitate and mainly smooth the integration of AO in clinical practice.
So thank you very much, Danilo. And I think your offer to collaborate on the database has been heard. Now, Michel, how about you in your department? I know that almost all patients are routinely examined with RTX1. So how do you envision using this new fast workflow feature?
It really was a game changer. Now the workflow is much smoother, and in our clinical research unit now we implemented all these procedures for new technicians. Now they learn directly the new features. AMD patients are now all having TFI images, so it's and both are quite simultaneously RTX1 classic, let's say classic AO and TFI, so it's not much longer for the patient, and it's much more informative. So as Danilo just said, we need to standardize our procedure to acquire the same kind of images as much as possible, even if it will not be possible for all features because there are also multifocal image to be considered, and that is difficult to standardize. But yes, I really encourage people using the RTX1 to switch to use us to capture and then get trained to these new modalities, which will greatly help the analysis of the different disease features.
So you just also mentioned TFI. So which of your patients will also be examined with this additional modality?
Well, first of all, any disease affecting the retinal pigment epithelium. So it's even in inherited retinal degeneration, we found indeed what we can see the pigment very well. Sometimes we don't realize that there's a pigment dispersion in these patients. So these will. So we're still in exploratory phase. So maybe even diabetic patients you may see hard exudates better with the TFI, yeah, and even hypertensive patient if in acute and severe vascular disease, if you have cotton spots, you see them better also with the TFI. So from the initial objective of just seeing the RPE cell, it happens that in fact it's interesting for many other features, and it's a nice addition to the RTX1 image. In fact, we need both now to analyze correctly these features.
Okay, thank you, and it's very exciting. Now, Carolina, I'd like to ask you about neurovascular response assessments. How are you implementing or using this functionality in Brescia?
In our department, first of all, we perform 3 technical assessments in different kinds of patients, including patients with autoimmune or oncologic disease who have been recognized to present a high cardiovascular risk Second of all, we are also trying to better clarify the clinical significance of thicker light-induced dilation by comparison the retinal microvascular disease across the other microvascular districts such as the heart or the kidney, and its relation with microcirculation or other form of target nodal damage in hypertension. And in this regard, the advantage is to combine the function and structure assessment with adaptive optic help to better stratify patients for cardiovascular risk. And there are other two important aspects. First of all, we should focus on whether the retinal macrovascular changes may be reversed by specific treatment, and if this ultimately results in a reduced cardiovascular risk. And as also Danilo introduced, the other aspect we should focus are the reference values and the standardization of protocols for retinal macrovascular parameters, which are actually lacking in order to make the results comparable in different contexts or different centers. And for these goals, of course, it requires the collaboration among different macrovascular research centers, and this really would help to better understand the macrovascular disease. So I encourage the different macrovascular research to put together all data and to establish the reference values.
Okay,
So,
thank you very much. And so thank you all for sharing your insights and also your intention. So maybe, but it's time to wrap up. So it's perfect timing. So I want to reiterate many thanks to our guests for sharing experience and their vision. And also thanks to all of you for joining this webinar. Have a good day or a good evening, and see you next time. Thank you.